I'm going to talk about the nodular and the reticular patterns. Let's start my presentation from the conclusions. As for all diffuse lung diseases, our task is to provide a specific diagnosis when possible, or more frequently, a shortened list of differential diagnoses. To do this, to better interpret the nodular and the reticular patterns, we first should familiarize with basic pathologic, radiologic, and even clinical correlations. Especially for the interpretation of the nodular pattern, we should also use a standardized diagnostic approach, also by using a standardized diagnostic algorithm. Let's start from the nodular pattern. We are looking at a nodular pattern when there are too many nodules to count on CT, and these nodules are generally less than 10 millimeters in diameter, and the distribution is widespread but not necessarily uniform. And it has been highlighted in the Fleischner glossary that the pattern distribution is very important and must be assessed systematically, and the nodules can be classified as centrilobular, lymphatic, or random. But when we are looking at the nodular pattern, we should systematically evaluate these three key HRCT features: perfusion, characteristic of the nodules, and distribution of the nodules. We should first optimize the assessment of the nodules perfusion. So we should get used to this kind of algorithm, namely the maximum intensity projection, which consists of projecting all the voxels with the highest attenuation values on the CT images. And this algorithm massively improves the evaluation of the nodules perfusion. In addition, MIP images also improves the evaluation of the nodules distribution and the nodules shape. Of course, we could already identify branching opacities in the standard CT images, but you can see that MIP images better depict the tree-in-bud opacities, the tree-in-bud pattern. We should also keep in mind that increasing slab thickness improves the assessment of the nodule perfusion. Generally, slab thickness of 5 to 8 millimeters is appropriate for the evaluation, for the assessment of the nodules perfusion. We should also consider the nodules characteristics. There are many types of nodules making up the nodular pattern. These nodules may differ for density, for margins, for uniformity in size, and other features. I would highlight these three types of nodules: fluffy centrilobular nodules here, tree-in-bud opacities, and diffuse, sharply defined nodules, because different groups of lung diseases correspond generally to these three types of nodules. For example, fluffy centrilobular nodules generally are consistent with respiratory bronchiolitis in smokers, and respiratory bronchiolitis signs are a common finding in smokers, or hypersensitivity pneumonitis, according to the clinical scenario. Tree-in-bud opacities generally reflect bronchial disorders, and the diffuse, sharply defined nodules are generally associated with granulomatous, immunologic, and even neoplastic disorders. Calcification and cavitation are also important features that must be assessed systematically and improve and narrow the differential diagnosis. Let's have a look at these four different examples. On the top left corner, you can see some random calcified nodules, and they were caused by a varicella infection. In this other example, you can note dendritic shaped nodules at the periphery of the lung, and this was a primary dendriform pulmonary ossification. More commonly, these types of nodules are seen in combination with lung fibrosis, more commonly a UAP pattern. In this case, I show you some dendritic nodules associated with an NSAP pattern in a patient with systemic sclerosis. And this is the striking appearance of the pulmonary alveolar macroerythesis. And this is the differential diagnosis of diffuse pulmonary calcified nodules. So previous infections, such as varicella, may cause diffuse or random nodules, ossification in lung fibrosis, more commonly in UAP, dendriform pulmonary ossification, metastatic pulmonary conditions, more commonly due to renal failure or hyperparathyroidism, occupational lung diseases such as silicosis, amyloidosis, and of course, pulmonary alveolar microlithiasis. Sometimes diffuse cavitating nodules look like these famous biscuits. That's why they've been called Cheerios in the lungs. And they are generally associated with metastatic disorders. More commonly, these multiple cavitating nodules are associated with cervical cancer or pancreatic cancer. And less commonly, Cheerios in the lungs are observed in lung cell histiocytosis. Generally, these cavitating nodules are less profuse as compared to metastatic disease, and the differential diagnosis is quite easy, as we can also note cysts and regular nodules in lung cell histiocytosis. Then we should systematically evaluate the distribution of the nodules. To me, it's less important to evaluate the regional distribution of the nodules. Nodules generally predominate in the upper and the middle lung zones or are uniformly distributed throughout the lungs. Less frequently, they predominate in the lower lobes, and this may be seen in pulmonary ossification or asbestosis, or less commonly organized pneumonia, and of course, in metastatic disease. These are the three key distribution patterns, distribution patterns. Let's start with the first one, the centrilobular nodules. By definition, they spare the subpleural regions. They may be seen at the absolute periphery of the lung, but they do not touch the pleural surfaces. And importantly, they spare the lung fissures. So we should carefully and systematically check the lung fissures, and MIP images are very useful to rule out the fissures involvement. In the vast majority of cases, these centrilobular nodules are related to the centrilobular bronchiole. So they reflect bronchial abnormalities. Very seldom they reflect small vessel disease, such as peripheral metastatic disease. Most often, these pure centrilobular nodules are fluffy or display a trim bud configuration. This is an example of a patient with hypersensitivity pneumonitis, and you can see fluffy centrilobular nodules sparing the lung fissures and the subpleural regions. This is another example of a patient with hypersensitivity pneumonitis. You can see fluffy centrilobular nodules, a decreased attenuation area representing gas trapping, air trapping. And this picture, this HRCT picture may overlap with that of a respiratory bronchiolitis, but very simple clinical information could narrow the differential diagnosis between these two different conditions. And we should also consider that centrilobular nodules are generally associated with the patchy ground glass opacity, because inflammation is also present in the interstitium and in the alveolar spaces around the bronchiole, the centrilobular bronchiole. That's why we often see patchy ground glass opacity merging with these centrilobular nodules. But it is important to identify the centrilobular nodules, because patchy ground glass opacity is a non-specific finding. But if we can identify centrilobular nodules, then we can narrow the differential diagnosis. This is the most common type of centrilobular nodules. The trim bud pattern represent, by definition, centrilobular branching structures that resemble a budding tree. So these opacities look like a magnolia, and the pattern reflects a spectrum of endo and peribronchial disorders. This is an example, a histologic specimen of a patient with atypical Mycobacterial infection, and you can see the bronchiole dilated, and its lumen is filled by exudate, fluid, and cells. But more importantly, there is a peribronchial inflammation, which gives the appearance of the trim bud configuration at HRCT. This is an example of a patient with primary TB, and you can see diffuse trim bud opacities, but you can also note that the trim bud opacity may have different morphology, which may depend on several factors, such as the orientation of the bronchiole to the plane of the scan. So it is possible that at some levels, branching lines may represent the most striking findings, whereas at other anatomical levels, centrilobular cluster nodules may represent the dominant finding, the most striking finding. As these trim bud opacities reflect bronchiolar disorders, they are often associated with larger airways disorders, such as, and we can see other abnormalities, bronchiectasis, bronchial wall thickening, and also decreased attenuation areas. We should not confuse trim bud opacities with other types of nodules, such as spiculated nodules occurring in sarcoidosis. Trim bud opacities, once again, are pure centrilobular nodules, and they cannot be seen in the fissures, so we should check the distribution of the nodules in relation to the pulmonary lobule. And dendriform-like nodules, such as those seen before and here in pulmonary ossification, may mimic trim bud opacities, so we should also sometimes check the density of the nodules. These are the main causes of trim bud, the trim bud pattern. At the top of the list there is, of course, infection, bacterial, viral, and fungal, but also congenital disorders, idiopathic disorders. Diffuse panbronchiolitis is the prototype of the disease showing diffuse trim bud opacities. Chronic aspiration, immunologic disorders is an asthmatic patient, ABPA. Connective tissue disease, especially Sjögren's syndrome, and less frequently, quite seldom, vascular abnormality, such as peripheral metastatic disease. The second type of distribution, the perilymphatic distribution, nodules can be seen are subpleural, septal, peribronchovascular, and also centrilobular. They follow the course of the lymphatic vessels. They are generally sharply defined, and they are seen in sarcoidosis and pneumoconiosis. Let's have a look at 3 different examples of 3 different patients with sarcoidosis, and you can see that the nodules here are concentrated, are predominant in perihilar regions, and we can see centrilobular nodules, nodules involving the fissures, and in this other example, the nodules can be seen here at the periphery of the lung, touch the pleural surfaces, and sometimes, quite often, we can note that the central bronchovascular structures show irregular margins due to the presence of several nodules involving the interstitium enveloping the core, the central bronchovascular structures. This is an example of a patient with silicosis. In silicosis, nodules show a perilymphatic distribution, but as compared to sarcoidosis, are more randomly distributed. Generally, nodules are larger and tend to conglomerate in the pleural regions, forming pseudoplaques. Random nodules are sharply defined miliary nodules, uniformly distributed throughout the lungs, and they are, of course, symmetric. So you can see nodules everywhere in the center of the lobules, involving the fissures, but they do not show any predominant relationship with any of these structures. They are just random. This is a classical appearance of the miliary tuberculosis. Of course, this is another type, completely different disease, showing nodules with a random distribution. You don't need to know the diagnosis. These are all metastases. But sometimes the differential diagnosis is not so straightforward between miliary nodules in TB and miliary metastasis caused more frequently by thyroid cancer, renal cancer. In this case, these nodules were metastases caused by a thyroid cancer. So we should consider clinical information, clinical findings, and check carefully all the lungs to to check for the presence of consolidation, which may represent, for example, lung cancer in these ambiguous cases. So this is a very simple diagnostic algorithm which improves the evaluation of the nodular pattern. We should first ask ourselves if the nodules are subpleural. If not, then the nodules can be classified as centrilobular. And if these centrilobular nodules show a trim bud configuration, then we should first consider bronchial disorders. And at the top of the list, we should first rule out bronchial infection. If these pure centrilobular nodules do not show a trim bud configuration, we should, again, consider bronchial disorders such as respiratory bronchiolitis, which is quite common. If symptomatic, it's called respiratory bronchiolitis associated with interstitial lung disease, or hypersensitivity pneumonitis. Less commonly, these pure centrilobular nodules represent vascular disease. Getting back to the first question, if the nodules are subpleural, are also seen involving the fissures and the subpleural regions, the pleural surfaces, then we should differentiate between lymphatic and random distribution and consider the list of diseases associated with these two different types of distribution. Okay, let's talk about the next pattern, the reticular pattern. The term is purely descriptive. A reticular pattern is a collection of innumerable small linear opacities that, by summation, produce an appearance resembling a reticulation. And of course, this finding usually represents interstitial lung disease. We should consider that different portions of the lung interstitium are predominantly involved by completely different groups of disorders. I will show you why. And the lines making up the reticular pattern may vary from smooth to nodular and irregular. It is very important to identify the dominant types of lines. So there are several morphologic variations of the reticular pattern. The size of the network making up the reticular pattern depends on the level at which the interstitial thickening is most pronounced. So these are the three key dominant reticular patterns. Diffuse interstitial thickening due to the presence of fluid or cell or fibrosis in the interlobular septi is well typified. In the most common condition is, of course, pulmonary edema, and you can see smooth septal lines outlining the pulmonary lobule. This is another completely different disease mimicking pulmonary edema, and again we can note a large size network made by smooth septal lines in this young female patient with a uterine cancer, and this, of course, represented lymphangitis, but these smooth septal lines were unilateral. So when these smooth septal lines are unilateral or very patchy, and if we know the presence, about the presence of a cancer somewhere, we should also consider lymphangitis. So sometimes the differential diagnosis between these two different conditions is not so easy. Of course, if the interlobular septal thickening is more irregular and even nodular, then we can more confidently diagnose lymphangitis. As a consequence of the continuity between the various portions of the interstitium, diffuse interlobular septal thickening is quite often associated with bronchovascular thickening. You can see here a good example in a patient with lymphangitis carcinomatosa, and you can see here bronchial wall thickening not related to a true bronchial disease, but this was caused by lymphangitis itself. So these are the most common conditions associated with the dominant interlobular septal thickening: pulmonary edema, lymphangitis, but also leukemic infiltration, eosinophilic pneumonia, pulmonary alveolar proteinosis with the so-called crazy paving pattern, lipopneumonia, veno-occlusive disease, amyloid, and of course, less frequently, it's a quite rare disease, Erdheim-Chester disease, but also Niemann-Pick disease. There are other diseases, but these are the most common conditions. Interlobular thickened septal lines can be also observed in many other lung diseases as an ancillary feature, as an occasional feature. You can see here in this example of a patient with sarcoidosis some septal lines in the upper lobes, in the ventral portions of the upper lobes, but you can note here that there are some nodules involving the fissures and bilateral lymphadenopathy. And this is another example of a patient with respiratory bronchiolitis associated with interstitial lung disease. You can note patchy glass opacity, centrilobular nodules, bronchial wall thickening, a bit of emphysema, and a few septal lines. So it can very often represent an occasional feature in several lung diseases, such as sarcoidosis, pneumoconiosis, more commonly in asbestosis, but also in idiopathic interstitial pneumonias, chronic HP, and bronchoalveolar carcinoma, or carcinoma in situ, as you prefer. Let's have a look at the second type, most common type of linear opacities. These are perilobular opacities that mimic the interlobular thickened septi, but this does not represent a true interstitial lung disease. These arcade-like polygonal and peripheral opacities are of greater thickness and less sharply defined as compared to the septal lines. And they are caused by alveolar filling at the periphery of the pulmonary lobule. And this pattern, these opacities have been reported almost exclusively in organized pneumonia, either in its pure form or more commonly in association with other lung diseases such as NSAP or even diffuse alveolar damage. So in a background of ground glass or reticulation, when we note this arcade-like peripheral opacity, then we can predict the presence of organized pneumonia. And this may be useful because we can also explain the symptoms of the patient, such as exacerbations of the symptom, for example. This is the last type of linear opacities. Intralobular septal thickening may be seen in several interstitial lung diseases, but it is well typified in idiopathic interstitial pneumonia, in which we can note fine intralobular septal thickening at the periphery of the lung. And this fine reticulation, of course, represents lung fibrosis and is also mixed with traction bronchiectasis. And in more advanced disease, more advanced lung fibrosis, this fine reticulation is associated with the coarser intralobular thickening and also with honeycombing. Honeycombing is a key finding at HRCT, as emphasized in the Fleischner glossary. This term should be used with care as it may directly impact patient care, because when we detect honeycombing, then we can suggest the presence sometimes of UIP, which is a disease which carries a prognosis even worse than some lung cancers. So honeycombing consists of clustered cystic air spaces, usually subpleural, very often subpleural, characterized by well-defined walls. So this finding should not be confused with other abnormalities, such as paraseptal emphysema, in which low attenuation areas lie on a single row, and these low attenuation areas are separated by integral normal interlobular septi. Whereas in honeycombing, the holes, the low attenuation areas lie on several rows and are separated by thicker walls. So my presentation doesn't have any conclusion. I show you the conclusion at the first slide, and I thank you all very much for your attention.